Good evening. My name is Evangelos Xilinas. I'm a professor of urology in Paris Cité University Bichat-Claude Bernard Hospital. Very happy to host and to moderate this webinar on non-muscle-invasive bladder cancer, treating about BCG unresponsive patients, management in 2025 and new developments. I'm happy to host today Assistant Professor Gauthier Marc from Lille University from France. Sharok Shariat, who is a professor of urology and chairman at the Medical University of Vienna, and Francesco Soria, who is assistant professor in Torino School of Medicine from Italy. So welcome, and we are going to start with a clinical case about a patient from Gauthier Marc, and then we're going to discuss the different options, so the intravesical bladder sparing approaches, and afterwards the systemic bladder approaches. And of course, we're going to have some questions, and we're happy to have your questions on the discussion for Q&A. So please, Gauthier, start with welcome and start with the clinical case.
Welcome, everybody. Thank you, Professor Xilinas, for this kind of introduction. And I want to thank the EAU for inviting me to speak tonight about this clinical case of one of my patients. So I'm Gauthier Marc. Nice to see you, everybody. This is my conflict of disclosure. So we're going to start right in with a clinical case presentation. So this is one of my patients. He's a 70-year-old male presenting with gross hematuria last year in January 2024. His past medical history is unremarkable for our bladder cancer patient with high blood pressure, right inguinal hernia repair, dyslipidemia, type 2 diabetes, atrial fibrillation. He is a current smoker, 30 years. He was experiencing hematuria with clots since several weeks when I saw him first. So we performed a TURBT on February 2024. The exam under anesthesia was not remarkable. We find some multiple papillary lesion. The resection was complete, and the pathology report showed a T1 high grade with concomitant CIS, no histological subtypes identified. The muscle was seen and was actually free of invasion, hence the PT1 high grade report. He underwent, of course, as recommended by the EAU guidelines, a second look TURBT within an acceptable time frame, and there was no visible lesion at the re-TUR. The pathology reports show no residual urothelial carcinoma. Therefore, and still according to our EAU guideline, he went through a BCG schedule and had his BCG induction in April-May 24. Prior this BCG induction, he obviously had a contranscendent CT with a urography that showed no evidence of disease, no upper tract disease. So he underwent this BCG induction. The following cysto was normal, therefore he started a BCG maintenance phase in July last year with 3 doses that was well tolerated, only minor grade 1 and grade 2 side effects that are well managed. And by October 24, he was able to receive the maintenance M6, 3 doses out of 3. Unfortunately, I saw him recently again with a cystoscopy showing a solitary papillary recurrence. So he underwent a new TUR early last month that showed a PT1 high grade, again, concomitant CIS, no histological subtype identified, the muscle was seen and free of invasion. Again, as our guideline states, every T1 high grade NMIBC should have a second look TURBT, which he had very, very recently. So I just saw him early this week with the result of the second look TURBT that showed no visible lesion. There is no residual urothelial carcinoma in the pathology report. His new CT showed no evidence of disease, and patient refused the standard of care treatment for this disease, which is a radical cystectomy, and he asked for a bladder preserving strategies. So here and tonight, we're going to discuss the BCG. So the patient is obviously BCG unresponsive, and we're going to discuss the bladder sparing approach. We have 2 esteemed colleagues that are going to dive into the literature about intravesical bladder sparing approach or systemic bladder sparing approach.
So thank you, Gauthier. So we have a case of a T1 high-grade plus CIS disease within 12 months of adequate BCG. So definitely it's a BCG unresponsive. And as you mentioned, these patients declined cystectomy, which is most of the patients in clinical trials declined cystectomy. So I think that Shariat is going to talk about intravesical options for these patients.
Thank you for the wonderful case presentation. I think this is a reality, the case we see today. It's not uncommon where we see patients that actually ask themselves, why should I have my bladder removed if at the moment I don't have an active cancer, or the active cancer is, within the certain lining of the bladder and could be controlled with drugs. So let me tell you what really the data behind the bladder sparing intravesical options are. These are conflicts in disclosures. Certainly I'm involved in clinical trials that are testing some of these therapies. So what is the goal when we think about the bladder? Is one, certainly eradicate the existing bladder, prevent or delay tumor recurrence. But once we get to the BCG unresponsive, it's about preventing or delaying progression and making sure this doesn't become a pan-urothelial disease, thereby also ensuring that we're not going to have a survival detriment. There's certainly a risk associated with it, and this is an old slide, but it still is so much true. So once you're diagnosed with T1 bladder cancer with certain risk factors, that is, puts you in a high risk or even in a very high risk, you could do immediate radical cystectomy. Now, one could give BCG, what is the case in most patients, which is understandable, in a high risk, and some of the very high risk EAU definition. And at that time, one could give radical cystectomy during the BCG treatment, but most patients certainly would try BCG therapy. Once the patient becomes BCG unresponsive based on the definitions that have been very clearly defined, the question is, can we give something in the bladder, or does it become a too late radical cystectomy if we need to trigger it? Are we losing the window of opportunity? One thing that is definitely sure, at the moment the tumor becomes muscle invasive and we trigger the radical cystectomy, then we certainly, even without macrometastasis or metastasis, it's a too late radical cystectomy because the outcomes are worse. So we have to make sure we don't lose that window of opportunity if we try salvage intravesical therapies. The standard of care, without doubt, which most patients don't like, and very understandably so, is that radical cystectomy for BCG unresponsive. Radical cystectomy leads to cure, not in everybody, but in most of the patients. If done well in a center of excellence with high volume, the quality of life is pretty good. Nevertheless, it certainly is an overtreatment in a large majority of these patients. And even in the best hands, you have a significant morbidity and mortality. And let's not forget about the body image that's changed and the cosmesis. The art for the future is going to be to identify those that need radical cystectomy, those that may need what Francesco will talk about, systemic therapy, because they have macrometastatic disease already unrecognized, and hopefully in the future recognized with ctDNA and others, and those who can be treated with intravesical therapy. So we're gonna see a multi-risk BCG unresponsive population. In identifying those patients, understanding them, and delivering the right therapy is gonna be the art. Let me jump over that. So there's been really a gold rush, I would say, to identify the best possible therapy in this BCG unresponsive space. There have been phase 2 and phase 3 studies. It is very important to understand that the FDA, who's been the trend-setting regulatory body in this space, and the biggest market is the United States for possible drugs, has defined that the single-arm phase 2 trials are okay, because it's very hard to randomize to radical cystectomy. and giving further intravesical therapy would be at major risk. These are all the possible studies that have been ongoing with different drugs and different therapies. Some of them, as you can see, Keynote 676 is systemic therapy with intravesical combined. Some are double intravesical combined, some single intravesical, and some are systemic therapy only. I will talk about only the intravesical because I think a large majority of the patients will benefit only from intravesical therapy in this setting. So when we assess these therapies, one needs to be very clear what are the criteria for a therapy in this space to be acceptable. Number one, we need to talk about the same patients for inclusion. So we talk, because a lot of older cohorts have been enriched with patients that were BCG intolerant or just were not really BCG unresponsive because they didn't receive the right doses of BCG. So that needs to be the right space we talk about. Whatever therapy needs to be easier and safer than radical cystectomy. That means it needs to be simple, less morbid, and widely usable. Then the second criteria, it needs to have clinical acceptable and durable efficacy. Now, what the definition of durable is I think very patient-specific one. For some patients, 2 years is good. Some patients want to have it 1 year and more, and then look further. In reality, it's definitely more than a year, I think, if you talk to patients about this. We need to make sure we don't risk the window of opportunity in case we give this intravesical therapy. We don't lose the window of opportunity if there's no response, the patient doesn't become metastatic or advanced. So that is very important. And if we need to have a salvage therapy like a radical cystectomy, those the therapy didn't work, they certainly should not be increased complications. And I think this space, and specifically bladder cancer, is a patient-centric disease where patients' wishes, hopes, and vision of their perception of their quality of life really matters. However, none of the studies have really reported the patient perspective and the patient wishes and as an outcome measure. And let's not forget, least, it's still important. This needs to be cost-effective, widely implemented. You would not be able to have a therapy that costs a fortune and given always again and again. I will talk about 2 or 3 of the therapies that have been FDA approved. None of them have been approved by the EMA, but the FDA has looked at this, set the standard, what is acceptable to them, and companies have come forward with clinical trials that have delivered on those endpoints. We're going to go through them, and they mostly are working on different actions. These that are quite similar. One is nadofaragene firadonovec. This is basically an interferon alpha that has a pleiotropic antitumor effect. That means the cells internalize this adenovirus. The interferon alpha 2b transcription leads to local production of the cell, the interferon 2 alpha, and you have then a direct cytotoxic effect, some immunomodulatory effect, and also some direct immune effect. So there's a very complex, multiple things happening here, but what are the results? So this is the trial that is in a single arm, open label, repeated dose clinical trial has been given intravesically to patients who were BCG unresponsive. Very important is when we talk about BCG unresponsive, there's 2 different cohorts of patients we're talking. Some of carcinoma in situ with or without papillary disease, and some are only papillary disease without carcinoma in situ. Now that depends if you're using some image enhancement or not, but these are different cohorts of patients, and every single drug has performed differently, with most of the drugs performing better in patients who are only papillary disease. So if you look at it, at 3 months, you have 54% of the patients having complete response. At 12 months, you have 24%. So this is a phase 3 trial with 151 patients, large duration. But what was the most interesting, there was no serious toxicity. That is very important. These are long-term data that have been just reported, very fresh from the phase 3 trial. looking at one endpoint that is very important, that is cystectomy-free survival and overall survival. If you look at it in a CIS-only population, 43% are cystectomy-free at 5 years. In a papillary disease, approximately 60%, 59%. So it's doing pretty well, and most of the patients are alive. You know, this patient population can die also with other causes. So it is also very well tolerated, no grade 4, grade 5. So that is something that makes it very attractive with long-term evidence data here in this case. And only 4 patients with CIS and 1 patient with papillary disease experienced muscle-invasive disease. So it's kind of really safe, not only well tolerated, safe oncologically to try it out. Maybe not all the patients have a benefit, but it seems. Real-world data from the Mayo Clinic have supported almost identical to the clinical trials. So that shows that even in a real-world setting, it works well. What is interesting, they've reported in the past that urine markers could help you assess the response locally as well, in addition to cystoscopy, which has some limitations, even with blue light and cytology in this population. There is another therapy that has received approval or fast track by the FDA. It's an oncolytic immunotherapy. So this therapy has also 2 mechanisms of action. It enters the cell and replicates in the cell and thereby lysates the bladder cancer cell, but it also triggers an anti-tumor immune response that is quite complex but very effective. So leading to what we would call a bystander effect, tumors around it being affected. Here are the data on this story. This is another therapy that is working a different mechanism. This is here a super agonist, IL-15 super agonist that is in combination with BCG. So after your BCG unresponsive, you add a super agonist, thereby activating and proliferating the NK cells and CD8 positive cells. This patient had 84 CIS patients, 71% 3 months complete response, and 45% at 12 months. Pretty impressive. The drug I was mentioning before, cretostimogene, works as a monotherapy, has been tested in BCG unresponsive patients with induction and possible reinduction. Don't forget, immunotherapeutics need sometimes longer to work and some sort of maintenance course. Most of the patient population look very good. What they did see, overall complete response of 76%, at 12 months, 46% still with complete response. Cystectomy-free rate at 12 months is 90%, and most of the patients are 12 months free from progression-free survival. So it's pretty impressive data. Here you see the Kaplan-Meier, see those that respond have a pretty durable response. Here is a combination with checkpoint inhibitors where you combine it with the IV form of checkpoint inhibitors, even better response, but less tolerable. One therapy that has been used widely in Europe that we use as well, but does not work that well, is the heated mitomycin intravesically. It works very good in patients who have no carcinoma in situ, but those that have carcinoma in situ, BCG unresponsive, the efficacy is not that great. Also, this population was a different one. One thing that has been used widely in the United States, but only has retrospective large series data, is a combination of intravesical gemcitabine and docetaxel. Results seem really impressive, but let's not forget, prospective trials have not yet reported on it, and we don't really know how good that's going to perform in a trial setting, not only based on selection that has been maybe the cause of the retrospective data. Here's a new concept. New technologies are evolving. This is a device and a slow release mechanism where gemcitabine or maybe even an FGFR inhibitor like erdafitinib could be released in the bladder if you have FGFR altered tumors or gemcitabine. The drug is very experienced and very effective, but a slow release mechanism. This is the Sunrise 1 study where they looked at this device TAR-200 is named, alone, or a checkpoint inhibitor IV, or a combination of the two. And they dose it very smartly. And if you look at the complete response rate, 84% of the patients had in a monotherapy only with the intravesical device. Combination was doing a little bit less good, and systemic therapy less good. And I think systemic therapy in general is not that effective in that setting. Now, if you look at the 12 months, obviously the arm with the combination does better because the systemic therapy has some long-term efficacy, but yet the TAR-200 monotherapy alone, 66%, amazing complete response. So here you have a table that you can see. This table is going to evolve. These are the ongoing trials. I talked about the BOND 003, this is the CRETO, the QUILT, that was a super agonist and BCG in combination, Nadafar-gene, Keynote 057, Francesco will talk about, and the Sunrise 1 and gemdosi. These are the ones that are most advanced in the disease and have already reported. Most of them, except the TAR-200 and the gemdosi, have been approved by the FDA in this disease state. If you look at it, most of them are intravesical, which makes sense, or transurethral. And if you look at the complete response rate, the Sunrise seems to have the highest complete response rate at any time, but you cannot compare it across trials. All the other ones look very good. At least half of the patients or more having complete response at some time. And then the maintenance at 1 year, this is, I think, the phase we're looking at. This is currently set as an endpoint that is interesting to us. At least keep your bladder for a year and have still responding. You will look somewhere between 40 and 50% across the studies. Here, CRETO seems to have the best results, but again, you cannot compare across the trials. They were kind of different. What is the most striking is that they all are very well tolerated, specifically when you compare it to the systemic drugs that have, serious toxicity, as we know from checkpoint inhibitors. Some of them have 0% or a very few. So this is the IBCG group, where many of my colleagues are participating, have set up, sort of a diagram how to use that. I think it's very nice, it's helpful. It doesn't really change much because all those drugs have been tested in these two different populations. In conclusions, what I want to say is definitely not forget that radical cystectomy is standard of care, but in patients who refuse, as the same as a patient that Mark really showed here, refuse or ineligible for radical cystectomy, one could counsel them and find some off-label drug. In the United States, it would be on-label based on the efficacy, toxicity, and what the patient expects. I think in the future, the treatment will be personalized based on tumor characteristics, makeup of the patient, real-world considerations, one we will see, and risk stratification of this group of BCG unresponsive. Will they be micrometastatic or only localized? Definitely, we need randomized trials in this space, but we're moving towards there. Thank you very much.
Thank you, Chirag. So this is a very nice overview of the intravesical options that are coming in. I liked your slide from 15 years ago, I think 2008, and I think we are witnessing, and you showed it, a paradigm shift in the treatment of these patients. And I think you showed the slide was like a BCG failure somehow at this point, was like the early cystectomy. And I think we are shifting towards early cystectomy being the cystectomy after one round of salvage, bladder sparing approach, whatever it is. I think that's something I wanted to highlight. We have some nice questions from the chat, and I'm going to ask the first one to Gauthier Marc. The first one is, what are the key criteria for defining true BCG unresponsive disease? And I think this is an important question to be really clear on the definition.
Exactly. That's a very important question. So there are very clear criteria based on the FDA definition. So that's why we needed a population to enroll and to select patients for clinical trials. So the FDA came up with a definition, a very strict definition. So the patient needs to have at least 6 doses of at least 5 out of the 6 doses of induction, and an additional 2 doses of either the first maintenance regimen or a second induction BCG. If the patient has a high-grade recurrence following 6 months following the last BCG dose, he will be BCG unresponsive, or if he or she has CIS 12 months following the last BCG dose, he or she BCG unresponsive. So depending on the recurrence and the mode of recurrence, if it's a CIS, it's up to 12 months following the last BCG dose, and the last BCG dose is very important because you can have BCG maintenance for a year and a half and a recurrence, and you can still be BCG unresponsive. This is very important to know. That's the definition. I hope I answer well.
Thank you, Gauthier. I think it's very clear. And we have a question on what's the percentage of high-risk NMIBC receiving adequate BCG? Do you have that depends on what we call adequate BCG. Is like the FDA definition of induction plus 1 cycle, or are we looking for a 3 years maintenance, which is like recommended by the EAU guidelines? I think that percentage may be different if you consider induction plus 1 cycle or 3 years of maintenance. Perhaps, Shirok, you can answer that question.
Well, I think the reality is much less than what we have reported from centers that report on the results. There was a study some time ago that looked in general, you get the 6 cycles or the 6 doses of BCG normally in 11 weeks. What happens in clinical reality is the patient shows up, your nurse, your physician assistant, or the physician himself does a dipstick, sees hematuria or maybe some leukocytes, delays it. The patient has some symptoms that are to do with the BCG itself. So I think it's not only they don't get all the doses, they also don't get it adequately, and that is a real problem in the reality. So because of that problem, that it's the large majority of the patient, actually, I would say, in the routine out there, there's a new field that has been defined, and that's BCG exposed or BCG experienced. So these are patients that got BCG, but they didn't get it according to the criteria of the FDA that was just discussed before, and they still may not benefit from further BCG despite not getting it correctly, and one wants to intensify or change the therapy to make sure they have a good response.
So some other questions are rising in the chat about market access, especially in the European countries, and where do we stand with EMA approvals? The question is really, are there being rejections from the new therapies are being rejected, or are not really, presented to EMA, and what is the cost associated with the use of these new therapies? Because also in our European markets, let's say, and health systems, it may be a major concern. What's your point, Shirok?
So I think none of us can really answer that because the companies have not decided on a price tag for the therapies for the European market. Most as far you, Evangelos and Gauthier and Francesco and many others are working with the companies trying to design trials in the European setting that would satisfy the regulatory agencies for approval. And that is very fragmented. So you need one to have a study in general they want in European patients. Then the second question is, can we do it in a randomized fashion? Do we have a standard that is the control arm, that is not radical cystectomy? Do we need to think about that? And that's what the EMA seems want before approval of these drugs in the European market. Most of the companies are working on designing trials to address the necessity of the EMA, but they have not been rejected with the EMA. And the cost then evolves out of this within each market will be, none of us can really tell at this moment, I guess. We only know it from pembrolizumab, which is a drug that's used intravenously.
Agree. And since in European countries, we don't have all these new therapies like TAR-200, nadofaragene, cretostimogen, and all the others, what are the options? Like you showed gemdosi, which in many countries it's off-label. Do we have any place for BCG rechallenge in some cases?
I'm happy to let my colleagues answer that. I can give you also a short sense of it. Yes, there's been, frequently a discussion if BCG rechallenge makes sense in a group of these patients. Certainly, in a very well-selected cohort, it makes sense. Let's not forget, if you responded to BCG for 3 years, and then you have, 3 or 5, 6 months afterwards, you're not going to be different than the guy or the gentleman or lady that does not respond at all, very short time, but an induction, even with a re-challenge or first maintenance. So I think it's a large heterogeneity, as Gauthier very well put it out there. It's, there's features that put you also at increased risk, lymphovascular invasion, subtype histology. If then you're BCG unresponsive and started with those, you're certainly going to be in a different risk group. So I think understanding which risk group may be benefiting from a re-challenge is also part of that risk stratification that we need to move to. But a recent study from MD Anderson showed that this is possible. In very well selected patients, we don't know how they selected, but some of them had really long-term benefit and kept their bladder.
Thank you, Sharok. I think it's very clear. We need more options, and today we don't have so many. I think we're gonna move to Francesco Soria and talk about systemic therapies, and we're gonna have more questions afterwards.
Thank you. Thank you, Evangelos. Thank you for the invitation, and thank you, Sharok, also for your presentation. It will not be an easy task to me coming after you, but I will try to talk about the systemic approach in BCG unresponsive disease. These are my conflicts, and we will start talking about the rationale of behind systemic treatment in BCG unresponsive non-muscle invasive bladder cancer. Then we will talk about current evidence and future perspectives. But of course, before talking about systemic treatment, we have to understand which are the main pathways of systemic treatment in non-muscle invasive bladder cancer. And these pathways are the well-known PD-1, PD-L1 pathways that involve systemic immunotherapy. And then we have the FGFR pathways that involve the use of FGFR inhibitors, erdafitinib. But starting from the first, what's important to know is that the pathway PD-1, PD-L1 is used by the cancer to escape the host immune system reaction. And that's why a lot of cancer, especially advanced cancer and also urothelial cancer, overexpress PD-1, PD-L1, or both. That's because the binding between PD-1 receptor and its ligand PD-L1 induces a downregulation of the T cells activity and subsequently a downregulation of our immune system. And that's why we tried also to see whether PD-1, PD-L1 could be expressed and overexpressed also in non-muscle invasive bladder cancer and not only in advanced disease. And we saw that, yes, the response is yes. About 30% of patients with the T1 high-grade disease can overexpress PD-1, PD-L1. And this percentage is even higher in CIS population. And of course, in all the trials, the overexpression of PD-L1 is associated with a worse prognosis and with increased disease progression. But what is even more interesting is the fact that the BCG treatment probably induce an increase in overexpression of PD-1, PD-L1. This is a nice study with 78 paired tissue samples of patients at the time of diagnosis and then at recurrence after BCG. And as you can see on the right on the screen, the use of BCG increases the expression of PD-1. So that's meaning that this is probably a good target in BCG unresponsive population. And that's why after probably 20 years of nothing from 2002 and 1998 with varubicin and gemcitabine, we moved to 2020 in which we assisted at the advent of immunotherapy in non-muscle invasive bladder cancer. Pembrolizumab received the FDA approval for CIS BCG unresponsive population. And this is because of the Keynote 057 trials As already pointed out by Sharok, all these trials are phase 2 trials with 2 different cohorts. The first cohort in this case was the CIS BCG Unresponsive cohort, 101 patients included, good complete response that in this case was 3 months without biopsy, complete response around 40%. And of course, no progression to muscle-invasive disease. These results led to the FDA approval, also because there was no probably treatment in this space. But we have to understand that the median duration of response was 16 months, and at 12 months, only 19% of patients were still in complete response. And on top of this, there is toxicity. We are talking about systemic immunotherapy, a systemic treatment to a localized cancer, and we see that we have more or less always 13, 14, 14% of high-grade adverse events. Last year, we also presented the data regarding the cohort B, the papillary without CIS BCG unresponsive disease. In this case, the endpoint is different, is the 12 months disease-free survival. This was 43%, and again, the median disease-free survival was only 7 months. So the duration of response is still not brilliant. And again, the rate of adverse events is always the same, 14% high-grade adverse events. So probably once one immunotherapeutic agent works, probably all the other work. And this is also true probably in this setting. Actually, the atezolizumab that was studied in the SWOG trial reached more or less the same results. But in this case, atezolizumab was not approved by FDA because FDA at the beginning requested a futility analysis because of the lack of evidence regarding the safety of atezolizumab in urothelial cancer. And the study did not meet the futility analysis endpoint, so it was closed. But in this frame time, all the population was enrolled. Therefore, we have final data regarding the CIS cohort. In this case, the primary endpoint was a bit different, was 6 months biopsy-proven complete response, that was 27%. But of course, if we want to compare the trial, the 3 months complete response rate was again 43%, was 41 in the Pembro, and duration of response 70 months, more or less the same. And it is also true for the papillary cohort with 18 months event-free survival. And of course, it is the same for toxicity. It is up to 20% serious adverse events and 2% of mortality due to treatment-related adverse events. And then we have the other pathway. We talked about the FGFR pathway. Why? Well, because FGFR alteration, or they are both mutation or fusions, are highly present in non-muscle invasive bladder cancer, especially in low risk, but even in 30% of high-risk papillary non-muscle invasive bladder cancer. And of course, they act as oncogenic drivers. Therefore, using FGFR tyrosine kinase inhibitors like erdafitinib could be really interesting in patients with mutated FGFR. And this has been tested in the TOR2 trial. This was a randomized multi-cohort phase 2 trial with the cohort 1 enrolling BCG papillary unresponsive patients randomized to erdafitinib or investigator of choice. And let's see the number because these are important. 240 patients were planned at the beginning, while the cohort 2 was just CIS patients, was an exploratory cohort with only 20 patients to be enrolled to receive erdafitinib orally daily. Well, the results have been published in 2023, but the study was closed prematurely due to slow accrual. Only 73 patients out of the 240 patients have been randomized regarding the papillary cohort. The results were quite good, and I mean really good, with 77% of 12 months recurrence-free survival. But again, the toxicity was quite high, with 18% of high-grade adverse events and treatment discontinuation in 1 out of 3 patients. We have also some insights from the cohort B, so the CIS BCG unresponsive. These results were presented in ASCO GU 2023, but only on 10 patients. So these are really preliminary results with a 3 months complete response of 100% and a 6 months complete response of 70%. So a lot of data, but I think we can stay here one moment to summarize current evidence and focusing before on the CIS cohort. where we see that immunotherapy alone, so pembro alone or atezo alone, share probably the same efficacy profile, around 40% of 3 months complete response, around 20% of 12 months complete response. And these results are probably inferior and with more toxicity compared to those of intravesical agents that Sharok spoke about, so nadofaragine and Anktiva plus BCG. We have good results probably with erdafitinib, but of course we need more data. And this is also the same regarding the TA, T1 core, so the papillary core without CIS, with 12 months event-free survival or of probably 40% for both pembro atezo, and these results are better probably for the combination of interleukin-15 superagonist plus BCG. Again, erdafitinib is 77%, 12 months event-free survival, but the trial was closed prematurely, so we need more data in this setting. So it appears that probably at now systemic treatment is inferior to intravesical agents for BCG unresponsive disease, both CIS and papillary, but it is probably not the end of systemic treatment. This is the basis for the next future, because the next future is plenty of new trial. This is another overview of ongoing clinical trials, phase 2, phase 3 in non-muscle-invasive bladder cancer. And if we focus on the BCG unresponsive disease, we can see that we have interesting combinations like the CORE 001 trial combining cretostimogen and pembrolizumab, the ABLE-22 combining nadofaragine and pembro or chemo, and the Keynote 676 combining pembro plus BCG versus BCG alone in BCG exposed. Some of them have already completed the accrual, and the CORE 001 has already been published. This is the combination of cretostimogen and oncolytic adenovirus designed to replicate in cells with retinoblastoma alteration. 35 CIS BCG unresponsive patients were enrolled, and in this case, the primary endpoint was different, was no more 3 months, was 12 months biopsy-proven complete response, and the results were really amazing, 57%, with 3 months complete response, 83%. So actually, these results doubled the results obtained with pembrolizumab alone. But what's quite impressive and interesting is the duration of response. Actually, median duration of response was not reached and was beyond 21 months when the study was closed. Regarding toxicity, well, it's always the same. Toxicity is related to the systemic immunotherapy, is again 14%. This is always more or less the same, and we should be aware of it, but we cannot change it probably. Then we have the ABLE-22. We are waiting for the first results in the study, the 3-cohort different study, BCG unresponsive CIS patients. And in the cohort 2, the nadofaragine is combined with intravesical gemcitabine, while in the cohort 3, the nadofaragine is combined with systemic pembro. And the Keynote 676, that is treating BCG-exposed patients, so those patients just receiving BCG induction. So this is a different population, and is randomizing patient to pembrolizumab plus BCG against BCG monotherapy alone. But this is not enough. We have a lot of interesting data regarding another immunotherapeutic agent, so durvalumab. This is the ADAPT bladder trial, a multi-arm, multi-stage trial enrolling BCG unresponsive patients in 3 different cohorts. Cohort 1 was durvalumab alone, cohort 2 was durvalumab plus BCG, and cohort 3 was durvalumab plus radiotherapy. The first results have been published, and among really only 27 patients, we can see that the rate of complete response in patients with BCG plus durvalumab, so the green line, is really good, with 85% at 3 months, 83% at 6 months, at 73% at 12 months. So the results were quite good, but this is not enough, because now a new cohort has been opened, and the new cohort is made by the combination of durvalumab plus gemcitabine. 40 patients have been enrolled, both CIS and papillary, and complete response has been reported 2 months ago at GU ASCO 2025 to be 89% at 3 months, with a quite low grade of adverse events. So really, really interesting data despite preliminary. So we have a lot of new trials coming, but we have to fix probably some points. And the points are that, of course, pembrolizumab has changed the way in which we think about BCG-unresponsive disease, because it has been the first new FDA-approved treatment for these patients. Despite we have a lot of but regarding immunotherapy. We know that immunotherapy seems to provide good complete response rates, but unsatisfactory duration of response. That means that we are probably just delaying definitive treatment and maybe losing the window of opportunity. Erdafitinib seems to work better compared to immunotherapy, but more data is needed. We cannot make definitive conclusion. And of course, treatment-related toxicity is high. We are talking about patients with localized disease, not in metastatic setting. So also the toxicity should be probably different. However, we have to consider that combinations of intravesical agents and immunotherapy hold the promise to prolong the duration of response. So we will need probably in the next future to see whether the complete response and the duration of response are worth the toxicity. And we will have to decide and to select patients for this treatment combination. Thank you very much for your attention.
Thanks a lot, Francesco, for this very nice overview. I think we have seen the intravesical options, the systemic options, and you try to push us towards like combination therapies. So one question in the chat is about in many countries we are facing BCG shortage on the BCG difficulties, let's say, and does it make sense to have like a combination of treatments with BCG?
Well, this is a good question, especially in US and North America. There is still a problem of BCG shortage, and so the question is good. But you know, we were discussing before with Sharok that probably some patients of BCG, the panorama of BCG-unresponsive patients, may benefit from more BCGs, from BCG reinduction, and this is the basis to combine BCG with other treatments, because probably some population of cancer cells may still respond to BCG. The others who are really unresponsive may respond to other agents, and that's why the combination works. It's like deprivation therapy in prostate cancer, for example. And so probably the concept is correct, and the applicability will be, of course, difficult based on BCG shortage.
Thank you, Francesco. I think it's clear. What do you think about combination therapies? You showed that there are different options like intravesical plus intravesical, intravesical plus systemic. And I think we are expecting cumulative toxicities with either approaches. What do you think?
Yeah, well, probably the majority of toxicity will come from the systemic approach, because we saw in the intravesical agents trial that the systemic toxicity is not a problem. Okay, there are, of course, the same adverse events. We, as urologists, we know we can manage because we are used to BCG and to local adverse events. When we talk about systemic therapy and immunotherapy, we are talking about a different profile of adverse events, but we have not to be afraid of these events. We have to start recognizing and treating these events, also because the landscape for BCG naive population will completely probably change in next future. In AUA, we will see the CREST trial, so the combination of immunotherapy and BCG. That's why I think as urologists, we cannot say, okay, these are adverse events we cannot treat these patients. We have to start recognizing these adverse events, and then probably to select which patient may benefit from the combination.
Thank you, Francesco. I think it's clear that there is going to be cumulative toxicity, and of course, this has to be balanced with the potential increased efficacy of these combination therapies. Perhaps a question for Sharok and then one for Gauthier. Sharok, what do you think of, you showed us 5 years duration of response, let's say, which was like cystectomy free, which is not exactly the same endpoint of nadofaragene firadenovec. And 50%, I think, cystectomy free seems very interesting, even if, you know, cystectomy free is somehow a biased endpoint because it depends also on people that are declining cystectomy. So what do you think is 5 years, let's say, duration of response that makes a standard of care therapy?
Well, that is a very good point. I think, as I mentioned there, and Francesco also mentioned that very well, and you said that as well. The one thing is you don't want to lose the window of opportunity, and that is to become metastatic, advanced, or in a situation that will trigger significant toxicity of therapies to salvage the situation. Number one. Number two, none of these trials have any patient-centric endpoint. Because yes, you can keep the bladder, but it's in a bad shape, or you have pain, or you have significant toxicity. Yes, you're cystectomy free, but you got checkpoint inhibitors, and you have significant long-term toxicity from it, maybe not measured. So the quality of life, the patient-centric endpoints that are not measured, but need to be measured, are very important to assess for the patient. Was it worth it? Is the bladder and the quality of life, because you want to keep the bladder because of the quality of life and the risk associated with surgery. So that needs to be the endpoint that is quintessential without losing the window of opportunity. So I think it also really depends, and why that is important and needs to be patient-centric is because it depends on the patient preferences, right? The one that is 50-year-old gentleman that has two young kids like me, well, he's going to be more risk averse. He wants to keep his bladder, but he doesn't want to take too much of a risk. 5% of losing the window is just too much of losing the window. And he is going to have less complications with the cystectomy, the control arm that we cannot do in a clinical trial, which is different in an elderly patient. And as you mentioned, cystectomy free gives us a feeling, but the problem of cystectomy free is it's triggered by clinical decision and may not be triggered by disease biology. It's not a good endpoint.
I agree on that. Thank you, Sharok. That's very clear. Quick question for Gauthier. It's a little bit out of the scope of today, but I think it's an important question. Is there any role for reduced dose of BCG in BCG shortage areas?
So there are some trials actually that look at that. So there are trials that look at a third of a dose BCG. So that's there is actually randomized data looking at this, and doing a third of a dose for high-risk patient is inferior to full dose BCG. So ideally, you want to use a full dose BCG whenever available, but in a case of a shortage, it's acceptable to use a third dose of BCG.
Exactly. That has been shown by the EORTC trial.
Exactly.
There is a question on do we have these new methods evaluated in the earlier stage of a disease? And I'm going to answer this one. Yes, there are trials in BCG naive setting, either like compiling BCG plus immune checkpoint inhibitors, systemic immune checkpoint inhibitors. There is also a trial combining TAR200 plus PD-1 inhibitor intravenous versus BCG in high-risk BCG naive NMIBC. So yes, these therapies are also being tested in earlier stages of the disease. Thank you. That's one of the questions. And
maybe one thing that is very important, and I think Evangelos is also, can we, with these new therapies, at one stage come to the point that we avoid TURBT and all those things? It could be thinkable in the future. In intermediate risk, this is going to be certainly a concept that's going to get into. In a high risk, maybe it's a little bit challenging, but maybe we'll get to that point one day.
Yeah, I think that the recurrent low-grade disease, it's a very nice field of trying these new therapies as like ablative therapies, let's say. I think there is like a setting there to implement these new therapies and avoid recurrent TURBs that we know harm the bladders and therefore impact negatively the quality of life of patients. And I think that's that's a nice area also to test these new therapies, definitely. I think I don't have any more questions, and we answered most of the questions that were asked in the chat. So unless you have any questions, Chirag, on Francesco or Gauthier, I think I'm going to conclude. We had a very nice case on a patient that had BCG adequate therapy for high-risk NMIBC and unfortunately became BCG unresponsive. We discussed the options since he declined radical cystectomy of intravesical bladder sparing approach. When we discussed about the systemic, especially immune checkpoint inhibitors and also targeted therapies, and also looked at the combination therapies of intravesical, systemic. And I think that at the end of the day, we don't have anything available yet in Europe, except perhaps gemdose, but I think that new therapies are coming in, and exciting times are ahead of us in NMIBC, and we are looking forward to it. So thank you very much for being with us tonight, and see you in other webinars organized by the European School of Urology under the European Association of Urology umbrella. Thank you very much, Chirag, Gauthier, and Francesco.
Bye.
Thank you, Evangelos. Bye,
A
guys.
pleasure. Thank you.
Bye.